Good morning. We will be looking at the information from Chapter 18. I do want you to realize that so much of what we do when we assess children, infancy through adolescence, mimics what you've already learned, but there are some unique nuances in assessment. That's what I want you to focus on the unique health assessment aspects when you are assessing infants, children, and adolescents. So the areas of assessment for infants, children, and adolescents has to do with physical development, cognitive, social, emotional, and there's some unique things within development for these children and infants age groups. There is in-depth assessment physically every visit. And then there's a general cognitive and social emotional development at every visit. But then there's scheduled times within a child's growth and development that you look more in depth at cognitive development, social and emotional development. Stages of development. This is just for clarity. And look at the tremendous range. So a newborn is birth. Infancy starts after birth through 12 months. Early childhood, 1 to 4 years. Middle childhood, 5 to 10 years. And adolescence, 11 to 20 years. They look at adolescence in 3 different stages, early, middle, and late. And I know that you all understand the tremendous variances in these huge age ranges of development. So when we look at vital signs throughout development, we do a couple things that are unique when we're assessing infants and children and adolescents. We obtain a height at every visit, not just once a year or annually, weight at every visit, and it's very important to calculate BMI as an objective measurement to calculate that child's height-weight ratio. Head circumference is measured at each visit up until 36 months, and blood pressure assessment begins at age 2. One of the things for review, I remember when I was an undergrad learning about the APGAR scoring system, and then when I became a parent, knowing what my child's APGAR score was very important to me. So this is just a review of what APGAR scoring system is looking at, the clinical signs, and 1 minute versus the 5 minutes, how we rate those. This just to reiterate what you've already been taught in your undergraduate education. So this slide also begins with sequence of examination for a newborn. And I think it's interesting because, and appropriate, that our author starts with careful observation of activity. You know, we're trained observers. 85–90% of what we do and how we take care of people comes from professional observation. And that's no different than with a newborn or infant, child, or adolescent. So infancy. You'll note that in the book, a huge portion of that chapter is spent in infancy. And I think that that reflects that it is the most rapid rate of growth from 0 to 12 months. You know, about 6 months, the baby should double in weight. At the 12-month mark, these newborns are tripling their weight with a 50% increase in height. And it's really important in infancy to start non-disturbing maneuvers early versus potentially distressing maneuvers like looking in the ears and the mouth and palpating the abdomen. And the book does a great job in a review for you how to sequence your exam. But there's not a perfect way of doing it. You will develop your own technique. So I like this slide, and I like it in the book. Just as a review of looking at the fontanelles and at the suture lines. And I think the whole point, and I'll pass through the next couple of slides that ask you a question is just remembering about the anterior and posterior fontanelles. That posterior fontanelle closes around 2 months of age, and then the anterior fontanelle's huge range from 4 to 26 months. So really knowing that normal variance is reassuring to parents. In infancy, there are a few unique features of that infant exam. You can see as this is organized, that's very much like we do in an adult, but there's a couple of things that are unique. One is that only the ethmoid sinuses are present at birth. So knowing that really helps you just visualize the skull and the facial bones and structures and what you're looking for. The other thing that's unique for an infant evaluation is palpating the gums and the teeth. Look at that variance, 6 to 26 months of age for tooth eruption. And they say an average of 1 tooth per month. I don't know that I've experientially seen that. I've seen once the baby starts getting teeth, they can get several per month. Central and lateral incisors should erupt first, and the molars come last. So this asks a question that's just reiterating about anterior and posterior fontanelle and the time, and the need that parents do ask this question. So we continue with the infant physical exam features. I think what's important in this that grabs my attention when I'm assessing the thorax and the lungs is that the thorax of an infant's much more rounded in infants than in older children and adolescents, and I think that's why that the sounds are louder and harsher, and I think that's also why percussion is not helpful in infants because of the anatomy. And I think you have to have some skill to distinguish between upper and lower airway sounds. And the Bates gives us the distinguishing features, but because of that harsh, louder sound, you have to learn to differentiate that. It just takes practice. Here, when we're assessing the heart of an infant, we are making a huge attempt in the beginning to watch that infant and inspect for cyanosis. You know, the cyanosis might not come until you get that baby kind of riled up in your assessment. So you're looking at it when the baby is still and comfortable, and then you are assessing for cyanosis during the entire exam, really perioral or peripheral cyanosis. Really the most easily palpable pulse is the brachial, not the ulnar. So we're using that brachial pulse. And if you remember from CPR for an infant, that's what you're measuring, is you're trying to assess for that brachial pulse. The PMI is not always palpable. It does happen to be one interspace higher than in adults, and you are palpating for thrills. So you want to auscultate S1, S2. A split's normal, but fused together as a single sound during expiration. It just takes a while to listen, just practice listening. S3 is frequently heard and is considered normal. And then, of course, we're trying to listen to functional murmurs versus pathologic, but that's beyond what I want you to know. You are being introduced to that, but I just want you to know those normals and recognize that there are abnormals, and we're trying to differentiate. In this next slide, as we progress through our evaluation, just note that enlarged breast in a newborn is related to is secondary to maternal estrogen, and you are palpating for masses. I always do breast exam in my newborn and my infant exams. Male genitalia, you're assessing for if they're circumcised versus non-circumcised. You've got to retract that prepuce and inspect the glans penis. You're looking at the urethral meatus. Is it central or is it high or low as In hypospadias or hyperspadias, you are inspecting for descended testicles in the scrotal sac. And I also do hernia checks or assessments on my babies using my my fifth digit, my pinky finger, to go up into that inguinal ring and assess for that. Female genitalia is inspection only, and then one feature of that newborn is you're assessing that umbilical cord remnant. The average, it usually falls off 2 weeks. Sometimes it's longer. Auscultate all vowel sounds. And you can palpate the liver edge 1 to 2 centimeters below the costal margin, which is considered normal. And the spleen is often, the tip of it is palpable. A rectal is generally not done, but in those newborns, we are looking for patency. And that would be the reason why you'd be looking. Musculoskeletal, our textbook does a really good job of giving us visual photographs of this. As I tell students that I precept, I want you to visualize the entire skeletal system in your mind as you learn to inspect the spine, the clavicle, hips, legs, feet, knees. Once you visualize, then really putting the information together about ligaments and tendons and muscles you become much better at it. But in these infants, please visualize the skeletal system. Bow-legged growth to age 18 is considered normal. And the other thing I really appreciate in our text is that nervous system assessment and how do you assess cranial nerves in newborns and infancy. And this is a nice review of those newborn reflexes and infant reflexes. So the author actually gives us information on tips for examining a young child, that 1 to 4 year old, and much of those exams can be done in a parent's lap. And you allow the parent to participate as much as possible, even undressing that child. And if the child's just unconsolable because you approach and they're frightened, just allow a short break. And I often do make a game. One of the things I do with an otoscope is I shine the light down on the parent's hand first and then the child, and we try to catch the little ball. So you'll develop techniques that put the child at ease. And here's just the sequence tips for a young child. So you start with the child seated and examine the eyes and the neck, percuss and auscultate. And then you move the child to supine as you develop a relationship with them. End the patient upright with throat and ears. I think that's a good recommendation. Here's some unique physical exam features in the young child. What comes to me is that noting that the maxillary sinus is present at age 4. Some more unique features, talking again about liver and spleen edge palpation and scratch test to palpate for the liver size. Again, the author mentions that the testicles should be descended, and if they're undescended by age 1, you'll refer. I generally refer before that. And then knock knees from 18 months to 4 years of age. You really want to pay attention to that so that you can make an appropriate referral. And if a child can stand, it needs to be assessed for scoliosis, or they do. Here's a question and answer. Middle childhood, physical exam is more straightforward. And then just some suggestions of sequencing. Interesting that the sphenoid and the frontal sinuses, look at when they present. And then adolescent, the Tanner features that are present for adolescents: breast development, male puberty, and female puberty. Thank you for your attention.